So my name is Sarah Garcia. One more time, I'm a PhD candidate in sociology at the University of Minnesota. And so thank you for joining for this breakout session today. Today, we're going to be presenting work in progress on neighborhood level inequalities during the COVID-19 pandemic. And I apologize, you'll probably hear a baby crying in the background. I'm technically on maternity leave, so we're having to finagle schedules. My husband will the baby just woke up, but he'll handle her. But if you hear her, that's what's going on. Inequality and inequity are core tenets of public health practice. National frameworks like Public Health 3.0, Healthy People 2030, the National Prevention Strategy, and the revised 10 Essential Public Health Services all have equity at their core. Social determinants of health have become an important component of public health research and practice, but COVID-19 has shown that despite this focus on the social determinants of health, racial, ethnic, and socioeconomic disparities are still prevalent. This is a figure from a recently published paper by Wrigley-Field and colleagues, which shows that mortality rates for Black Americans, Hispanic Latino Americans, and American Indians are more than double the rates for non-Hispanic white Americans. Oops. Socioeconomic status also interacts with race and ethnicity to affect mortality risk. Socioeconomic inequalities may lead to a higher risk of COVID-19 mortality through heightened risk of exposure. Socioeconomically advantaged individuals may have more opportunity to socially distance through access to white-collar remote work, less crowded housing and transportation, and other resources such as the ability to pay for delivery services and essential commodities. Socioeconomically disadvantaged individuals are at heightened risk of exposure to COVID-19 because they're more likely to be essential workers, live in crowded housing, take public transportation, and lack other resources necessary for social distancing. Geography is also a well-established correlate of inequity. Institutionalized racial discrimination in housing, employment, credit markets, and consumer interactions created wide racial and ethnic disparities in socioeconomic status that manifest geographically. And as a result, Black, Indigenous, and other people of color, or BIPOC for short, are more likely to live in socioeconomically disadvantaged neighborhoods. Residential segregation, often racial and socioeconomic, also increases infectious disease risk through isolation and concentration. Isolation confines infections to segregated areas and prevents transmission to the rest of the population, and high-density areas increase the probability of disease transmission within a segregated group. Because BIPOC are more likely to live in segregated areas and to be socioeconomically disadvantaged, they're also at higher risk of COVID-19 mortality. What hasn't really been studied yet, though, is how geographic disadvantage interacts with race and ethnicity to predict COVID-19 mortality. And so that's what our project is. We examine the intersections of neighborhood disadvantage and race and ethnicity in COVID-19 mortality in Minnesota. This work emphasizes the social and economic circumstances that place BIPOC at higher risk of COVID-19, and it reduces the harmful biological explanation discourse that can prevent meaningful policy solutions. We chose Minnesota for multiple reasons for this project. First, Minnesota rapidly produces death certificate data electronically, and that makes data availability less of an issue for this type of work. Minnesota is also a hotspot for COVID-19 mortality. The state recently had the 10th highest COVID-19 death rate in the country. And then finally, Minnesota has some of the highest racial and ethnic socioeconomic disparities in the country. So for the data that we used for this project, we linked death certificate data, we used death certificate data from the Minnesota Department of Health Office of Vital Records for deaths occurring in Minnesota. The cause of deaths was derived from International Classification of Disease, or ICD codes, based on cause of death from the original death certificate. So you can see I'm showing an example of a death certificate here. So there's an immediate cause of death, and then there's a couple lines for a subsequent underlying cause of death. Anytime we saw COVID listed anywhere on the death certificate, we included that person as having died of COVID. We linked the death certificate data to the Area Deprivation Index, or ADI data for short, and this is a measure of neighborhood level socioeconomic disadvantage. ADI rankings were constructed using a combination of income, education, employment, and housing quality measures. The range of ADI is from 1 to 10, and I'll remind you of this later when we're looking at the data, but 1 from 10 1 to 10, where 10 indicates the highest level of neighborhood disadvantage within the state, and 1 equates to the most advantage. You can see in this graphic here, and if you can, I'm showing an image of Minnesota that has, it's multicolored. And you can see that more advantaged neighborhoods in Minnesota are more concentrated near the metro area, and more disadvantaged neighborhoods are concentrated in greater or outstate Minnesota. In this analysis, we use census tracts as our geographic measure of neighborhoods, and this more closely approximates a neighborhood than a city or a county. To give you a sense of the size of the tracts, I've included an image here, and it depicts each level of geography as the census defines it. So first, we have the state, which is the largest block, and then the counties are 4 blocks within the state. And then within the county, you'll see a census tract, which is our level of geography for this project. And within the census tract, there are block groups, and within those blocks. Minnesota has about 1,300 census tracts to give you some sense of how many census tracts are included. And here's just an example of a larger census tract in Minnesota. So this is Census Tract 1261 in Minneapolis. It's downtown Minneapolis. This includes about 8,000 people, and it's almost 1 square mile. So that just gives you a sense of the level of geography that we're working with. To examine whether mortality patterns vary by race and ethnicity, we conducted a race stratified analysis using race and ethnicity from death certificate data. We constructed a 2-category race group for this project, BIPOC and white. And we would have preferred, obviously, to break the racial and ethnic groups down further, but we weren't able to do so even after aggregating into ADI deciles due to the small geographic unit of analysis. So we just have 2 groups for this project, BIPOC and non-Hispanic white. We also distinguish between mortality in the 7-county Twin Cities metro area and the outstate greater Minnesota for the race analysis. While COVID-19 mortality has increased in rural areas, the majority of it remains concentrated in urban and suburban areas. We also included individuals who died between 2017 and 2020, and we calculated excess mortality, or the difference between the observed and expected mortality in 2020. And what we did was subtract the average mortality, the average sum of all mortality from 2017 to 2019 from mortality in 2020 for the entire year. And the reason we do this is that excess mortality incorporates deaths from COVID-19 and other causes indirectly attributable to the pandemic. In other words, it captures deaths that may be COVID-19 or COVID-19 related, but were not directly measured as such through a lab test. For our analysis, we first examined which ADI decile COVID-19 mortality was concentrated in, and then we stratified by racial and ethnic group. As a reminder, an ADI of 1 is the most advantaged and 10 is the most disadvantaged. And what I'm showing here is I'm looking at a 2-panel graph, and I'm showing the distribution of the population and deaths by ADI in the state of Minnesota. In other words, here we're looking at the total population size in Minnesota and the total number of deaths and how they're distributed across the ADI deciles. If the population size estimate is larger than the percentage of deaths in the ADI decile, that means the percentage of deaths is smaller than expected given the population size. And if we see that the percentage of deaths is larger than the population size, what that means is that deaths are higher than expected given that population size. So the figure on the left is 2017 to 2019 mortality, and the figure on the right is 2020 mortality. And you can see in looking at these figures that for both years, deaths are higher in disadvantaged neighborhoods. When we compare this, and they're similarly distributed between 2017 to 2019 and 2020. But when we compare this to COVID-19 mortality, we see a larger magnitude of deaths in the more disadvantaged neighborhoods. And we also see slightly higher excess mortality in 2020 in the more disadvantaged neighborhoods. Now I'm going to break it down by race and ethnicity. The first 2 figures I'm showing here are showing just the metro area. We can see that mortality was more pronounced in the more disadvantaged neighborhoods for both racial groups. Oh, excuse me. Oh, I'm sorry. Whites and BIPOC in the metro area generally experienced higher COVID-19 mortality rates compared to the same race counterparts in outstate. So the next 2 graphs that I'm showing on the bottom, we're looking at outstate. Although we can see that the highest COVID-19 mortality rates were to BIPOC in the most disadvantaged neighborhoods in outstate neighborhoods. So that's the bottom right. You can see how much higher the deaths are for BIPOC in outstate areas as compared to whites in outstate areas and in the metro area. For the second part of our analysis, we split this disparity into two parts using statistical decomposition. And the reason we did this is that so we could examine how much of the COVID-19 mortality disparity is due to BIPOC people living in more disadvantaged neighborhoods on average. The figure that I'm showing now shows the gap in BIPOC and white mortality rates associated with within and between ADI deciles. And in other words, since this is a little confusing, we're comparing whether the racial mortality disparities are due to differences in where each racial group lives in terms of neighborhood disadvantage. And we're comparing that to differences in racial mortality within the same neighborhoods in terms of advantage or disadvantage. And what I want you to notice here is to first just ignore the colors that I'm showing in these graphs and just look at the magnitude of each size of the bars. When we look at mortality rates, we can see that the racial disparity mortality grew substantially between 2017 to 2019 and to 2020, increasing by a factor of more than 2.5. So we see that racial disparities in mortality just generally increase substantially from pre-pandemic to during the pandemic. And then next, when we look at the colors and examine how much of the mortality disparity is within and between ADI deciles, or how much of the mortality disparity is due to BIPOC people living in more disadvantaged neighborhoods on average. And when we look at 2017 to 2019, we see a more equal distribution of those two colors. And what that means is that part of the racial and ethnic mortality in 2017 to 2019 was due to BIPOC Minnesotans living in more disadvantaged neighborhoods than white Minnesotans. And then is also partly due to higher mortality of BIPOC living in neighborhoods with similar levels of disadvantage. When we look at 2020 total mortality, that's the lower part, we can see the distribution shifted substantially to more racial and ethnic disparities within the same neighborhoods than between the same neighborhoods. We also see that similar shifts occurred in both COVID-19 mortality and excess mortality. Mortality disparities during the pandemic were more likely to be within similar neighborhoods than between neighborhoods with different levels of disadvantage. And we'll talk about more what that means, or what we think that means. So next we break this analysis apart into metro area and greater outstate Minnesota to examine whether we see different geographic patterns in mortality. And again, when we ignore the colors and we just look at the magnitude, we see similar patterns. The racial and ethnic disparities in mortality grew substantially during the pandemic for both the metro area and greater outstate Minnesota. Now let's just look at the metro area. In 2017 to 2019, we actually see larger mortality among whites than BIPOC. So that's what that negative, you can barely see it, but it's negative 15.8 in that top bar. And that's showing that actually within the metro area, again, we see larger mortality among whites who are living in similar neighborhoods in the metro area. And then there's a dramatic shift once the pandemic hits, where BIPOC have higher mortality within similar neighborhoods than white Minnesotans. To state this in another way, racial disparities in mortality before the pandemic tended to be associated with whites living in more advantaged geographies than BIPOC Minnesotans on average, while aggregate disparities during the pandemic were driven by BIPOC mortality net of geographic disadvantage. And then we also see, when we look at outstate Minnesota or greater Minnesota, we see similar patterns where the racial mortality disparities increased within ADI deciles in 2020. So what does all this mean? I just showed you a lot of visuals and a lot of data, but what are the main takeaways? Race and geography are risk factors for COVID-19 mortality, and they intersect in important ways. In other words, racial and ethnic mortality disparities grew enormously in 2020, and they grew inside of neighborhoods, not between neighborhoods. In other words, before the pandemic, we saw greater racial and ethnic mortality disparities between neighborhoods with varying levels of disadvantage. And then during the pandemic, we saw a huge shift where mortality was higher among BIPOC people living in neighborhoods with the same levels of disadvantage as whites. And most importantly, BIPOC Minnesotans have been more affected by the pandemic than whites at similar levels of disadvantage and have been affected more in general. A second main takeaway is that disparities vary by geographic scale. So we looked at metro and we looked at greater Minnesota and we saw some different patterns. And we also saw this shift again to more mortality disparities within neighborhoods. Deprived neighborhoods in metro areas are different from deprived neighborhoods in greater outstate Minnesota. And this varies by racial and ethnic group. So what are some of the implications of our findings for public health practice and for racial equity? Understanding that neighborhood disadvantage is a risk factor for COVID-19 and that race affects the strength of this association improves our understanding of the social determinants of health. And this can be used to strengthen public health practice for racial equity. To improve the social determinants of health and reduce COVID-19 mortality disparities, we need to consider racial and ethnic differences within similar within similar socioeconomic circumstances. We also need to consider varying levels of geography, not just within neighborhoods. Greater outstate Minnesota may need different interventions than metro area. Interventions that consider neighborhood contexts are more likely to be effective in reducing COVID-19 mortality and reducing racial and ethnic disparities in COVID-19 mortality than universal and indiscriminate intervention approaches. I would like to, I have some acknowledgements here. I would like to thank my co-authors, two of which are on the call and may be able to help field some Q&A for questions. Elizabeth Wrigley-Field, JP Leider, and David Van Riper. I'd also like to thank the Minnesota Population Center, the University of Minnesota School of Public Health, and the Minnesota Department of Health. And I look forward to your questions and feedback. And I also have provided my email address, sgarcia@umn.edu, in case you have questions or questions or comments after our talk. So thank you for joining, and I look forward to your questions and comments.
Thank you so much, Sarah. That was great. If anyone wants to jump in with any questions, that would be great. You can write them in the chat, but you can also just unmute yourself. Or if anyone has any comments or issues you'd like to discuss.
No questions, but just a comment that I thought this was a very thorough presentation, and I wasn't surprised about any of the information shared. I definitely would want this, your slide presentation and your stats, but definitely not surprised at all.
Yeah, I don't think we were surprised either. It seems that, marginalized groups tend to be the hardest hit with any catastrophe, and COVID-19 is no different. So we were also not surprised, but we're a little shocked in terms of some of the magnitude of some of the effects, but not surprised at the general findings. And I do believe that the presentation slides are going to be available, right, to all conference attendees.
Yeah.
And I'd be happy to share. We have currently this project, we have a paper under review at a health journal, which we hope to be published soon, but we'd certainly be happy to share more information if you'd like it.
Awesome, thanks.
Any other thoughts or, yeah.
I have one. This is Kathy Norleen, and I apologize. I was a little bit late. I had to sign out and get back in because I was bounced out. But did you have much comment, Sarah, on, I know that there is like, I can't remember the name of it, but it's like a neighborhood disadvantage map that you can go on. I think CDC is part of that. Did you use that for this project, or did you go straight to the census tracts?
Oh, that's a good question, and it's a little bit complicated. I might pull in one of my co-authors, Elizabeth Wrigley-Field, to comment on this. We used both census tracts from the census data, and we also actually used census block group data for part of the analysis. And there are different reasons why we used each, but we did use the area deprivation index data that we used for the neighborhood disadvantage uses census block group data. So that was one reason why we used census block groups for part of it. But for the racial analysis, we used census tracts instead. And I think I'll let Elizabeth comment on that further.
Hi. So I think the thing you're asking about is the social vulnerability index that the CDC uses.
Exactly.
Oh, I'm sorry.
Yes.
Okay, I misunderstood the question. Okay.
So the social vulnerability index is a great index that is doing something very similar to the area deprivation index that we use, but with one big difference, which is that the social vulnerability index has direct measures of race and ethnicity and also of language spoken in an area. And the reason why those are included in the social vulnerability index is that those are important dimensions of which areas are likely to be hard hit in a disaster and need special outreach and an influx of resources. But for our purposes, since what we wanted to do is understand what role is neighborhood playing in racial disparities, we didn't want to have race incorporated directly into the neighborhood measure. And so that's why we use the area deprivation index, which is only economic measures. It's things like the unemployment rate and the poverty rate, but no direct race measure, so that we could see how those things were intersecting with each other.
Thank you for that explanation.
Thank you for the question.
Are there any other questions or thoughts? I'll throw something out there while waiting for anyone else who wants to speak up. Sarah, I saw that the research that you're interested in is really about the intersections of disability with race and disadvantage. Maybe you can describe that better, but I was wondering how you're seeing, especially after doing this work, COVID contributing to some of this disability, what you think that might bring you towards in the future, looking with different populations or working with different populations.
Sure. Well, I think I haven't examined disability and COVID-19 specifically. I think there's in terms of, like I was saying before, any marginalized population I think is harder hit. And I think with COVID and disability, there's probably going to be a lot of issues surrounding access to maybe, barriers to being able to get vaccines, barriers to healthcare. That I haven't, that's just my guess or my theory. I haven't been able to examine that. The one, I don't want to say like positive thing about COVID, but I think there's been some silver linings in terms of more flexible schedules and also allowing more remote work with the pandemic. And I think that's actually been useful for access. There's people that may be accessing this presentation right now that may not have been able to access it in person. So I think there's been some good that's come out of this, but of course, I'm assuming that there's also been harm to the disabled community, but I haven't been able to study that explicitly. Hopefully in the future, there'll be more data and I'll be able to do that.
I mean, obviously there's so much with COVID that the data is coming out at the same time as we're trying to do all of this work. And it's been hard to get a handle on anything but the little world you're inhabiting. But thank you. That's, again, great perspectives on all of this. Is there anyone else who'd like to say anything or any issues you'd like to bring up? How this impacts your own work, how you're seeing some of this in your own work. We've got a wide array of public health people here and community members.
I'll speak up again. This is Kathy.
Thank you, Kathy.
Elizabeth. I'm willing to wait if somebody else wants to talk. I just was at the breakout session that talked about resilience. And I think those people who are making it through these difficult times will have a larger toolbox to build for their resilience. And I see that being very needed, especially some of our more highly impacted communities are the same communities that will be hit when we look down the line at climate change and the things that are happening in that venue. I don't know if somebody else wants to jump in and give us your opinion. How about the panel, Sarah and Elizabeth?
I think that's a really great point, and something we don't talk enough about is resilience. Yeah, so I think, yeah, that's a great point in general, and that is something we should talk about. I guess what I would like to say in terms of going back to disability and resilience, that I think as we see certain disasters increase and global climate change, that that certain populations will have, they have skills that the general population doesn't necessarily have. So for example, with wildfires, people with respiratory disabilities have ways of being able to kind of minimize and ameliorate issues associated with respiratory distress from wildfires. So that's just one little example of that, where I do think that we definitely might see, we definitely will see resilience in certain populations, and I'd love to hear others' thoughts on that as well.
Yeah, I was going to jump in on that. And I was in the breakout group with Dr. Glenn, and I'm blinking on his last name. Glenn is his first name, from Minnesota. You're not, okay. Well, anyway, he talked about resilience and how, and it is a mixed bag, right? Because I know personally that resilience is huge, because in many communities, we've had to learn how to live in certain conditions, how not to allow those conditions to destroy us, right? So we've become stronger in some instances and able to rely on our resilience. That has also become a negative, because the point that he was making, sometimes folk expect you to make that work for you, and other folk not have to do anything else for what's happening in the situation. And so I guess I would just want to stress the point he was making. No, bring the funding, bring the help, whatever help you have for that situation, but don't poo-poo on people because they have certain amounts of resilience, because we've had to build that resilience in order to, you know, it's a survival skill, right? But it's not saying that we don't need other assistance to be able to navigate through these situations. So, and I know I've heard people sort of downplay resilience. Well, I don't want to talk about resilience because that's not what it's for. Well, I'm proud of resilience, and I'll put it in wherever it needs to be put in, because I know for some folk, if it were not for resilience, the road would be much tougher.
Thanks for bringing that forward. You know, why it came to mind to me, I have a college-age son, and the sky was falling. Everything, the sky was falling. And I think he's finally beginning to see you can work through things and get to the other side. But, you know, I don't know, it may be helpful for all of us, but maybe the inner side. That doesn't mean to say I agree with you, Ella, that funding and other resources need to be, that can't be used as a crutch for that.
Maybe one way we could think about it, I really appreciate this conversation about resilience. And maybe we could think that there's an institutional aspect to resilience. Like if one of the things that's emerging from these neighborhood results is that the economically deprived Twin Cities metro neighborhoods were really experienced the COVID pandemic in a way that is unlike every other kind of neighborhood. And, you know, so what kinds of resources do those neighborhoods need? That should be an institutional question. A vaccine can be a kind of resilience. What kind of vaccine access did they have? And then there's maybe another dimension of resilience that is more about the self-organization. And I think that in some ways that has begun to happen in the pandemic. Like I was really impressed with some of the mutual aid organizing that's happened, some of the kind of community organizing for vaccine access and against evictions and things like that. But it really feels like we're at, that's a lot of ways in its infancy. And so I think when you're asking about things like climate change, to me, that really poses the question very starkly about, you know, is that kind of self-organization of community and that type of resilience going to be able to deepen in a way that will allow people to survive and look out for each other? And I hope so.
There is a question in the chat. I don't know if we're going to have time really to answer it, but it was to me privately, excuse me, so not everyone's seeing it. This audience member is asking if, since we looked at census tracts, if we have specific recommendations of areas that should be the focus for vaccination. And like Elizabeth was just mentioning that that we see racial and ethnic differences within these neighborhoods, even within the most socioeconomically disadvantaged neighborhoods. So I think that I don't think we have looked at particular tracts or particular neighborhoods necessarily. It's more just thinking about generally how that realizing that we do need to think about race even in these micro geographic levels. And then we also need to look not just in the metro area, but consider how different geographies within the state affect these racial and ethnic COVID mortality differently. Elizabeth, do you want to add to that? Anything to that?
No, I think that's a perfect ending, right on time.